My name is Elizabeth Salisbury-Afshar, and I live and work in Madison, Wisconsin. I'm a family medicine, addiction medicine, and public health physician. And for a little over a decade now, I guess my work has really spanned clinical practice and public health practice. Right now, I work for the University of Wisconsin in Madison, and I have a mix of clinical practice, research, public health practice, and teaching. My clinical work is both in the hospital on an addiction consult service, and I'm the medical director of a walk-in clinic for people who use substances. I also serve as the medical director of harm reduction services for the Division of Public Health and am the program director for the public health residency at UW-Madison. So continuing to kind of have this clinical public health split. Particular, what I would say is that I always love having the opportunity to write for AFP because it's really practical and applied, which is sort of my favorite space to work in. It's really trying to understand the totality of the literature and then thinking about, all right, but what do we do with this in a busy primary care practice? How would someone apply this? I've also had the opportunity to write a few editorials, really talking about the role that family physicians can play in delivering addiction treatment in their communities. And I've really enjoyed those opportunities, just to think about sort of, again, where the rubber meets the road. Okay, so there's all this evidence. We know it can happen, but how do you do it? How do you do it when you're already really busy with a big panel, short, visits that are too short? And sort of how do we build in this direction to be able to offer more comprehensive and holistic care? I think that family physicians employ harm reduction every single day. Um, when we think about how many times do we work with patients who have hypertension or type 2 diabetes, and we've given them guidance on making dietary changes, exercising more often, losing weight. These are chronic health conditions that are very closely related to many lifestyle factors, many behaviors. It's about meeting people where they are, understanding that behavior change is hard. And for anybody who's ever gone on a diet, right, it's usually not perfect. For anybody who's ever set a goal about exercising, it's hard to make a dramatic change and have it be perfect from there on out. And it's kind of a similar idea, I would say, in the healthcare space. If people are coming to us wanting to talk about their substance use, it's typically because they want to make a change. Now, maybe their end goal isn't abstinence, or maybe it's not abstinence from all substances. But really, if we use the same model that we use for other chronic health conditions to say, really the goal is reduce morbidity and mortality, it's actually a super easy fit. And I think when I started embracing the harm reduction mentality, sort of got away from this idea that like my goal has to be that everybody stops using all substances because that's what I think is going to be best for them. And I started really listening to the reasons people had continued use, to the ways it allowed them to cope, and just started truly brainstorming with them. Okay, so maybe abstinence isn't on the table right now, but is there anything you could do to improve your health? What would that look like? What are some small changes you can make between this week and next, right? And a lot of people do get there. But again, sort of taking my biases out of it and just listening and understanding where people are coming from, understanding what their goals are, understanding the roles substances may be playing, and making a really, really rational, pragmatic sort of plan. And really with an end goal of reducing the risk of death and reducing the other negative health consequences, and just sort of being there to walk alongside people, helping them find resources, offering medication so it's appropriate. We're doing it all the time. We just aren't as used to doing it for this specific chronic health condition. Human beings are not like three separate, we're not like our physical health, our mental health, and our substance use as three separate things. And so, truly, if we want to be providing evidence-based addiction care and supporting people with substance use disorders, I think it's going to take finding ways to integrate those services and making sure that we're treating people as whole people, right? So you're not just your substance use, you're not just your mental health condition, you're not just your physical health, but really understanding that we need to have teams, understanding the person as a whole, and also helping patients understand sort of these interconnections, right? So I'll use alcohol again. If you're drinking heavily and really struggling, with sleep problems, anxiety, hypertension, those things are likely all interrelated, but we're treating them all as if they're separate in many cases. Another example of why family medicine can do this work so well. So I do think that it's going to take a lot of work to kind of build bridges or even bring everybody back under the same roof to be able to really provide that holistic, comprehensive care. And so I think, there are some programs, we just need to see them scaled, both to help recruit people into the workforce, to help offset the cost of that training, and then to make sure that people are being paid a competitive wage and a wage that allows them to live, basically, to be able to afford housing and food and childcare, et cetera. And so I think there's a lot of work that can be done around workforce in substance use disorders in particular.